So today is the case-based discussion on acute myocardial infarction, and the organizers are Dr. Gunadhar Padi, Dr. Asif Iqbal, and Dr. AKLESH Tandekar. He is also our moderator for today. He is an HOD, Depth of Critical Care, Wockard Hospital. We have our examiner today here is Dr. VINOD Singh, who is a senior consultant and academic coordinator and Director of ECMO Programs at Sir Gangaram Hospital, New Delhi. And the case presenter that we have here today is Dr. Santosh Thakur, who is a MD Emergency Medicine in third year, DRNB CCM resident at Workot Hospital. So you can start right now.
Santosh, can you please start?
Start.
Santosh, yeah, please go ahead. Vinod sir, I mean, if you're ready, if you're okay, can we start the presentation?
Yes.
Yeah,
You can start.
yeah, sure.
So, good evening, everyone. Myself, Dr. Santosh Thakur. I am third year critical care medicine resident. Today, I'm going to present a case on acute coronary syndrome, acute myocardial infarction that we encounter in our day-to-day practice in critical care. So, on presentation in ER, there's a patient, 50-year-old male with no known comorbidities, was brought to Wockhardt Hospital in ER by the relatives with complaint of retrosternal chest pain since 4 to 5 days, the pain was progressive and has increased now. Patient had chest discomfort associated with diaphoresis, also associated with shortness of breath. On presentation in ER, patient has a heart rate of 106 beats per minute, blood pressure of 140 by 110 mm of Hg, respiratory rate of 35 per minute, and oxygen saturation of 82% on room air. Blood sugar was 144 mg per deciliter, and on auscultation, patient had bilateral core scripts. Patient on examination was conscious but extremely restless, tachypneic, and obeying command. On presentation to ER, immediately within 5 minutes on presentation, the ECG was taken, where the patient had sinus tachycardia and associated with ST elevation in the anterior leads, and also the QRBB pattern suggestive of acute ST elevation MI. This was another ECG taken within 10 minutes, where patient had ST elevation in V1 to V3 and also QRBB pattern. So on presentation in ER, initial ABG suggestive of a metabolic acidosis with lactates of 8.9. Though on presentation the blood pressure of the patient was around 140 by 110, still patient was in shock. Initial hemoglobin of 16.2, total WBC count of 10,000, platelet of 3,37,000, creatinine of 0.83, sodium 136, potassium 3.7. The cardiac enzymes were elevated, that is TROP-T of 122, CPKMB 28, and NT-proBNP of more than 20,000. Immediately chest X-ray was also done in ER.
Dr. Vinod, you wanted to say something?
Hello.
Hello? Yes. You're audible, sir.
Now, can you go to the ABG?
Yes, sir.
So, what is the ABG finding?
Sir, patient had mixed acidosis. Bicarb was low, and the expected carbon dioxide was not that low. Patient was also in distress for a prolonged period of time. Maybe patient was retaining carbon dioxide as patient was getting drowsy.
So usually, the patient does not retain carbon dioxide. So maybe some other problem also. And now you go to the X-ray.
Yes, sir.
What is the X-ray findings?
Sir, X-ray was showing bilateral battering opacity suggestive of acute pulmonary edema. Also, bilateral peribronchial cuffing is seen, and prominent pulmonary artery is also visible, and suggestive of acute pulmonary edema.
Now, whether the patient has got any history of COPD also?
No, sir. Patient did not have any comorbidities, but patient was a chronic smoker.
So this X-ray is also suggestive of COPD.
Yes, sir. Tubular heart is also.
Could be, yes, your patient has got a mixed metabolic as well as the respiratory acidosis, because the risk factor for MI is also a risk factor for COPD. Like if and long-term smoking, that could be also a risk factor for COPD. The patient definitely had got COPD.
Yes, sir.
Okay, you can go ahead.
So for initial management in ER for respiratory distress, initially patient was put on NIV support to decrease the work of breathing. Patient was requiring 60% of FiO2 with maintaining a oxygen saturation of 93%. Patient, on the basis of ECG changes and cardiac markers, patient was immediately loaded with dual antiplatelets, aspirin of 300 mg, clopidogrel 300 mg, atorvastatin 80 mg, and low molecular weight heparin 60 mg. Subacute stat was given. Patient was also having coarse creps, and patient was in acute pulmonary edema. 40 mg furosemide was given, IV stat, and patient was started on tirofiban infusion at 7 ml per hour. An immediate plan for revascularization was done, and plan to shift to cath lab was done. In ER, echo screening was done, suggestive of severe LV dysfunction. Patient had RWMA, enteroseptal wall, with severe LV dysfunction, EF ejection fraction of 15 to 20%, and IVC was full.
So can you go to what is the standard treatment for MI in ER? If the patient has got a ST elevation or the patient has got a chest pain or suspicious of MI, how do you manage in the ER?
Sir, once the patient arrives in the ER, immediately we do the ECG, start with the supplemental oxygen. If the patient is in respiratory distress, we have to manage the airway breathing circulation. And on the basis of ECG, immediately we start with we load the patient with antiplatelets if there is a acute coronary syndrome, and plan for revascularization as soon as possible.
No. The question is that if we are loading with the antiplatelet, what is the standard recommendation? Do you combine the clopidogrel with aspirin, or you give only aspirin?
We combine with aspirin.
Which recommendation? You combine the clopidogrel and aspirin? See, usually there are two types of recommendation. One is the European Society of Cardiology or American Heart Association. Okay.
Yes, sir.
So you are telling that your patient has got a acute ST elevation MI. Okay.
Yes.
So oxygen is okay, morphine is okay. You have not given morphine because the patient has got a respiratory acidosis also. Aspirin is okay. And low molecular weight heparin, I don't know which guideline says that at the time of emergency you get low molecular heparin in ST elevation MI. And diuretic, of course, if the patient has got an LV failure, you can go for diuresis. And okay, tirofiban, okay, fine, and you have shifted the patient to the cath lab for revascularization. Okay. The only controversy to me is whether to give clopidogrel or not. Anybody? Sir? Sir is there?
Oh, yes.
Yeah.
Yeah, Dr. Vinod, you wanted to ask something? Yeah.
Yeah, whether to give clopidogrel at the time of coming to the casualty or not. Dr. AKLESH?
So, generally, the AHA also recommends uh, uh, 300 milligrams of ecosprin and 300 milligrams of clopidogrel to be given loading. Am I audible?
Okay. Yes, yes, you are audible, sir.
Yeah. So these are the AHA recommendations. But when we feel that the thrombus burden may be very, very high, so in that situation, probably you may have to think about these ticagrelor or agratoban infusion that this patient had received. But these are the recommendations based on the thrombus load. Usually agratoban, all these or tarifiban infusions are given post procedure. I'm not sure why this patient received tarifiban before this patient was taken for revascularization. There are better agents compared to clopidogrel. And now you have ticagrelor and better antiplatelet agents. So this can also be given.
Okay.
And apart from that, I think anticoagulation is also very important. Either heparin or a low molecular weight heparin should be given. If there is a kidney injury or kidney dysfunction, heparin is preferred and fractionated heparin. But if the kidney functions are normal, low molecular weight heparin also should be given. Some books also recommend initial dose of half of the dose, if 0.1 milligram per kg of low molecular weight heparin. Half of the dose can be given IV, and the half of the dose can be given in subcute form also. Because when the patient presents with cardiogenic shock, the subcute injections may not have adequate therapeutic effects because of the poor absorption through the skin and subcutaneous tissue. So some centers also give half of the dose IV, and then later half can be given subcutaneously. I would like to hear from you also, sir, on this aspect.
No, that's fine. But
Hello?
only question is, hello? Yeah. Am I audible?
Yeah, you're audible, but your voice is low.
Okay. See, giving heparin is, if at all heparin has to be given, it should be unfractionated heparin. In case of acute ST elevation MI. Okay. But if you are planning for a thrombolysis, you may not think for giving heparin also. But here we have separated the patient for the cath lab. So I would like to hear what has happened after that. So we can continue with the case.
Yes,
Yeah.
sir. So on echo, so there was severe LV dysfunction with ejection fraction of 15-20% with anteroseptal RWMA.
Okay.
Patient, there was a little time lapse for shifting the patient due to some financial constraint. By then, the patient was hemodynamically unstable and there was NIV failure. We had to intubate the patient before shifting to cath lab, and patient also required vasopressor and inotropic support. After which the patient was shifted to cath lab. Coronary angiography was done, which was suggestive of triple vessel disease. There was complete occlusion of left anterior descending artery, which was the main culprit vessel. PAMI to LAD was done, and in view of cardiogenic shock, patient was also put on a IABP support prior to doing a prior to putting a stent. So this was the angiography finding, where there is 100% occlusion of LAD.
Russian for main language. Sorry, I'm the.
Sushmita ji, can you please unmute the audience? Thank you. Go ahead, Santosh.
Almost 80 to 90% occlusion in the RCA and around 70-80% occlusion in the LCX. So the culprit vessel LAD, that was the plasty was done for LAD, and later stage plasty was planned. And before this plasty, IABP support was also put for the patient and shifted to ICU. These were the IABP findings, where the augmented pressure was 104, systolic assisted pressure was 96, unassisted was 94, and diastolic assisted was 77 and unassisted was 71. And patient was shifted to the ICU. Patient was requiring triple vasopressor. There was noradrenaline, adrenaline, and vasopressin. Very restrictive fluid strategy was used, was given by PPV and IVC guided fluid resuscitation was done. And after a while, we even had to start albumin infusion as the patient was requiring requiring more fluid. Patient was then conscious, arousable, and was kept on fentanyl infusion. Patient was still intubated. After 3 to 4 hours, patient had episodes of ventricular tachycardia post the angioplasty. This was the ECG post plasty. Patient was having ventricular tachycardias. Patient had recurrent episodes of VT, which was initially corrected by pharmacocardioversion. We had to give quadron, amidron infusion, even and xylocard infusion. But due to persistent VT, electrical cardioversion was done with 100 joules. We had to give shock for almost 6 times. And then we got the sinus rhythm and gradual tapering of next 12 hours, gradual tapering of inotropic support. And presently patient is on was on noradrenaline vasopressin infusion. We could taper off the adrenaline infusion. Patient is still on IABP support, requiring 1:2 ratio with maximum augmentation. This was the ABG, present ABG, where the acidosis was corrected and lactate is still 4.4. Patient is still sedated, paralyzed. Patient FiO2 requirement is still 80% with the oxygen saturation of 93%. We had continued furosemide infusion at 4 ml per hour. Gradually, in next 24 hours, that is the third day, inotropic drugs were tapered off. IABP support was withdrawn by evening. In next 24 hours, patient was tolerating spontaneous breath trials and extubated on 4th day. Thereafter, patient was mobilized, physiotherapy was done, and day after, patient was shifted to the wards and was planned for staged plasty later.
Okay. Can you go back to the first slide? What is there in the discussion? You had some theoretical aspect.
Yes, sir.
Okay. We would like to have case discussion. Okay, so it's better that we discuss the case right from the beginning. As you know, as you highlighted that your patient presented to the emergency room, 50-year-old gentleman, smoker, came with the retrosternal chest pain. So, what are your differential diagnosis that you should think about in this case? You have jolted out already that you will follow ABCD approach, airway, breathing, circulation, and all that. You manage this patient. So, what is your provisional diagnosis based on this first slide that you have? Is it okay, Vinod sir? We can take the
Yes.
questions. Yeah.
Yeah.
Yeah. So this will be a long case in the exam for DR and B students. So this is how the cases are presented, and we ask the questions in the exam. So go ahead. Yeah, please tell us, Santosh.
So, sir, with this with differential diagnosis of chest pain in ER, firstly, we'll have to rule out the ACS by doing the ECG, that is STEMI, NSTEMI, or unstable angina. Secondly, other cardiac causes can be pulmonary embolism, aortic dissection, pleural diffusion, even acute gastritis can cause severe chest pain. Uh,
But you cannot make a call while you are on another.
Aortic aneurysm, and so these are the probable common emergencies that we see in ER that present with acute chest pain.
So how do you clinically differentiate or suspect aortic dissection?
So there is severe pain, especially towards the back, and bilateral pulses are unequal. We see the pulse in both the hands, and even the BP is different in both the upper limb.
No, BP is not different in both the upper limb. If you are suspecting a dissecting aortic aneurysm, okay, the most common site of dissecting aneurysm is where it can happen. It can happen either ascending aorta or descending aorta. Okay, if you are having in the descending aorta, somewhere you'll find bilateral absent femoral pulse. That is one of the most important diagnostic criteria. And if you, any patient who has got a chest pain, you should must palpate the both femoral pulse. Because these patients, if you are suspecting MI or ACS, they are going to receive the thrombolysis. So you should must rule out clinically whether your patient has got a femoral absent or not. Of course, if it is a descending aortic, then the patient might not survive because of the cardiac tamponade, or they will have all the features of the cardiac tamponade. But mostly challenging situation is the dissecting aneurysm, which is in the descending aorta type.
And sometimes you will also have a patient who will present with retrosternal chest pain, which was out of proportion. Patient will be diaphoretic. Okay, his blood pressure also may be elevated, and you may see that this patient may not survive. They may not reach the hospital at times, and even if they reach the hospital, they may get arrested and they may present with CPCR. Okay, so that's why we have to keep in mind that aortic dissection is one of the possibility that we need to think about. Okay, there are other differential diagnosis that you can think about. If the patient has pulmonary embolism, patient will have unexplained sudden tachycardia. They will also have desaturation. They will have chest pain. Okay, and then you do 2D echo, you will have RARB dilatation. ECG may show probably S1Q3 T3, which may not be present in all the cases, but the gold standard is pulmonary angiography. And for COPD patients, these patients will typically present with dyspnea, or they may present with rhonchi, they may present with severe respiratory distress, which is not settled with the diuretics, and you will have to continue NIV and BiPAP. So these three important diagnoses you should think about: COPD exacerbation, pulmonary embolism, aortic dissection. Okay, these are very important differential diagnoses. So over to you, Vinod sir. You can take the questions further.
Now, you rightly said that the differential is very important. Of course, the first priority is to exclude the ACS because this is the thing that requires urgent and emergent management. So we can go to the next slide also. You can see what was the clinical ECG finding, of course, is a typical finding of ST elevation in the right axis, right-sided leads. And next, already we have discussed about the ABG finding. What is suggestive of COPD is that the patient HB is also high and the patient's PCO2 is also high. And this is a mixed acidosis, which is suggestive that the patient will have. What you have missed is blood glucose, which is 434, or I'm not sure 454 or 434. So you have missed about the ketone. Have you done the ketone in such patient, whether your patient was diabetic or not? You have told that it is not a comorbidity, but why the blood sugar is so high?
Santosh,
Yes, sir. Yes,
I
sir.
hope we
Patient
are
did
all
not have any
audible to you.
comorbidities, but when he was admitted here, the sugars were persistently quite high. Patient was on continuous HI infusion, and I don't have the A1C level. Patient was
So,
diagnosed diabetes here.
So
so
may
this,
not given, so patient may not have given the history, but the patient is probably a diabetic. So the two risk factor already we know, diabetes, and also the patient has got a chronic smoker, whether the patient was hypertensive or not. Because if such a low cardiac output, the patient blood pressure was still high. So we do not know what was the baseline blood pressure of your patient. Maybe the patient is also hypertensive.
Yes.
and this may be a presentation of a decay. Sometimes, the patients with myocardial infarction, the precipitating factor could be diabetic ketoacidosis. It may be their first presentation. Patient may be diabetic. They might not have screened their blood sugars ever in their lifetime, and they may directly present with the decay. And the decay may be a precipitating cause of acute myocardial infarction in this patient. So, how will you manage this patient? How will you investigate this patient? Uh, as far as your clinical findings and these investigations are concerned, how would you investigate?
Sir,
Santosh?
yes, sir. On the basis of the initial labs and the clinical presentation, we have a probable diagnosis of acute coronary syndrome. So we'll
Tosh,
check
tell me the full diagnosis. It is not only the acute coronary syndrome. Your patient has got acute
yes
coronary syndrome with cardiogenic shock.
with cardiogenic shock. So
So we should not miss this when we are talking about the diagnosis. And
Yeah.
background history is to tell that the patient has got a suggestive of COPD and diabetes and probably diabetic ketoacidosis. So the probable working diagnosis is that the patient has got a background history of COPD and the diabetes, possibility of diabetic ketoacidosis and acute coronary syndrome, ST. It is not acute coronary syndrome only. Now you have the final diagnosis,
the
acute ST
elevation.
elevation, MI with cardiogenic shock. This is the full functional diagnosis to work up.
Yeah. As very rightly said by Dr. Vinod, you need to come up with a proper diagnosis, and you should give this complete diagnosis before we could go ahead with investigation further. So how do you investigate this patient? You've done ECG, and anything you would like to also rule out from the ECG or your blood test that you have done? What is the algorithm that you follow when your MI patient comes in the ER? So, what is your algorithm of management?
Immediately we get the ECG done within 10 minutes and we'd send the cardiac enzymes, that is troponin and CPKMB. And
Why do you send CPKMB? Any importance of CPKMB?
so CPKMB is a cardiac marker that is elevated from initial 2 to 4 hours and can remain elevated up to 3 to 4 days. So if there is any cardiac injury, ischemia or infarction of cardiac myocyte, CPKMB will be elevated.
Okay, but do we do routinely CPKMB, Dr. Vinod? Do we do CPKMB
Patients with
routinely?
chest pain and ECG changes will
Yeah, we don't do in the emergency. First, once the patient has come in the emergency, we are just doing the high sensitive troponin or just tropi, and that is sufficient to rule in and rule out the MI because you are focusing. In MI, you have a focused investigation. You don't do CPKMB.
Yeah. So that's not recommended. Yeah. So you can take your brief history, brief examination, and you will try to facilitate this patient for definitive intervention, maybe in the form of revascularization
right.
therapies for these patients. So, what is the checklist for revascularization before you take this patient for revascularization? What?
There is one question from the audience. I'll just reading this question related to this. This is he's a doctor, Lichte from Indonesia, if I'm pronouncing correct. I want to ask about how do you primary PCI could affect significantly on the patient's outcome. If there is still no facility of PCI center, is there any alternative treatment to prevent this acute myocardial infarction worsen? Thank you. So, nutshell, he wants to ask, what is the impact of PCI and thrombolysis on the patient's outcome?
Santosh, you would like to answer?
Sir, I don't remember of any study supporting this, but definitely the mortality is improved with primary PCI that is done. And the other question that he asked was, what is the other alternative where we don't have a PCI facility? So we have to thrombolize. The antifibrinolytic therapy has to be given.
So there are only 3 treatments for the revascularization. One is thrombolysis, the second is PCI, and the third is CABG. Okay. Now, the study has shown that the thrombolysis has got a better survival if you are not giving anything or you are not doing anything. And this is the oldest study which has shown that if you thrombolize 1,000 patients, 21 more patient is going to survive. But PCI done within a stipulated time will has much better outcome than the thrombolysis. And there are definitive indications for the CABG if your patient has got a artery which is amenable to CABG and the patient is in cardiogenic shock. So there are definitive indications for all, but the treatment of choice, if you have a PCI center nearby, is the PCI. This is the standard of care for MI, ST elevation MI.
Yeah, so I would also like to add a few important points. So, if the facility doesn't have a cath lab and you can't do PAMI, so it is better to load the patient. Okay, and you can also think about thrombolizing these patients. Okay, if the facility is far off, and it is going to take more than 3 hours or something like that, so you should try to thrombolize this patient as early as possible. Earlier the thrombolysis, better is the prognosis. But thrombolysis is a blind procedure, blind technique where you give injectables, thrombolytic agents, especially tenecteplase or retiplase or altiplase. So either of the thrombolytic agents are given, but you are not sure whether the thrombolytic agent is going to open up the artery completely. You need to later on also see and do angiography and have anatomical localization. So with the angioplasty procedure, you can actually anatomically localize, and you can treat that problem, the clot or thrombus. So you have diagnostic and therapeutic advantage of treating that myocardial infarction or the thrombotic occlusion that patient has developed. So given a choice, the thrombolysis has to be done within 3 hours, which is the window period, because in myocardial infarction, the dictum is time is muscle. The more you lose time, whether thrombolysis or whether PAMI, the myocardium is going to get damaged, and there will be substantial myocardial injury. The patient may not recover from. So, given a choice, if you don't have a center or a facility where the cath lab is not available, you should thrombolize this patient and transfer that patient to a definitive center where the cath lab is possible. And don't just keep the patient over there, but transfer the patient. And during transit, also during the transfer, the patient should be accompanied by the doctor, proper monitor, defibrillator, because post thrombolysis the patients may have arrhythmias, patient may have hypotension, so all these sorts of problems may be encountered. So accompanying doctor and the nurse and defibrillator, all such support system should be provided while the patient is being transferred to the definitive center. I hope this is sufficient. Dr. Vinod, you would like to say anything on this?
No, there is one more question, Dr. Anklesh. The other question is that is Jan from the Indonesia, and he's asking what is the role of inflammation in ACS? So, Dr. Santosh, you want to say something?
Yes, sir. Inflammation also plays a very important role in by which it increases the infarct size in ACS, especially in
Yes.
STEMI.
Mm.
That is where the role of ACE inhibitors, beta blockers come into picture, where they try to decrease the size of infarct. Once the patient is stable, we can start with these agents.
Yes, yes. So inflammation has got a post-infarct inflammation has got a definitive. One of the treatment option is that to control the inflammation and to by giving the beta blocker ACE inhibitor also. Okay. The other question is that is Johnny from the Indonesia again. I want to ask: is the patient is a candidate for percutaneous coronary intervention or a patient who has a candidate for a CABG? Dr. Santosh.
Right, didn't get the question.
So how would
No.
you decide whether you should take the patient for angioplasty or you should straight away take the patient for
For
CABG?
CABG.
Yeah.
So, sir, there is a critical left main occlusion. The patient usually goes for coronary bypass and complete triple vessel occlusion. Patient requires bypass surgery and also depends on the patient's hemodynamic stability. If the patient is extremely unstable, we usually try to revascularize one of the culprit vessels and maybe later plan for the stage plasty or bypass.
Yeah. CABG is a more of an elective procedure. It is not done in emergency, especially when the patient has presented with a cardiogenic shock. And patient may not withstand the surgical stress. Patient is already in stress due to that cardiogenic shock, and on top of that, if you directly take that patient for surgery, he will not withstand the surgery. So you have to restore the normalcy, you have to restore the physiological alteration that is developed. So such patients are initially treated with anticoagulation, antiplatelet, NIV support or ventilator support, or if required, these patients can also be benefited with intra-aortic balloon pump. You stabilize, decongest the patient, let the myocardium settle, and probably later on, if your revascularization therapies have failed or your anticoagulation therapy or thrombolytic therapies have failed, you may do CABG later on in interval when you are not able to do angioplasty, but straight away taking patient for CABG is not recommended. I hope that is sufficient. So,
So,
what is the TIMI risk assessment, Santosh? When you go for revascularization procedure, what is TIMI risk assessment?
TIMI, TIMI is a risk stratification score used for acute coronary syndrome. That is for, we have different score for unstable angina and NSTEMI and different for STEMI. So that predicts the mortality on presentation itself for post revascularization, mortality at 14 days. And so there are various variables for TIMI score, that is risk factors for ACS and use of antiplatelets in last 7 days.
So, in a TIMI risk stratification, you should look at the age. So, this scoring system tells you about the prognosis or the outcome of the patient post revascularization. Okay. So basically, any patient whose age is more than 65 years or more than three coronary risk factors, or any patient who is already on aspirin or more than two episodes of chest pain within 24 hours, or the patient has ST elevation which is persistent more than zero point 0.5 millimeters of mercury, or if the patient has elevated biomarker, if these factors are present, these patients have very high mortality. So the TIMI score risk is calculated with 1 point on each aspects, and if the risk score is more than 3, these patients should undergo early invasive procedure, which may be in the form of angioplasty and along with that anticoagulation and antiplatelet. As your patient is on tirofiban infusion, his TIMI risk score is more than 3. Okay, because he's a smoker, he's elderly, and his chest pain was also prominent, and he had ST elevation which was more than 0.5 millimeter. So these are the patients with the TIMI risk score more than 3. They receive early revascularization therapies, and they also receive concomitant tirofiban or eptifibatide integralin infusions, and they should also be loaded with clopidogrel before taking this patient for surgery. But if the TIMI score is less than 3, these patients can be managed conservatively. Okay. And non-invasive cardiac test, and further patient need to be evaluated with Holter later on. These patients need to be monitored. But if the TIMI score is more than 3, these patients definitely need a procedure. If the TIMI score is very high, 6 or 7, the patient's major cardiac events or the risk of organ failure or risk of morbidity, mortality is more than 41%. And with the TIMI score less than 3, the morbidity and mortality is less than 13%. So TIMI score also predicts morbidity, mortality, but it also predicts the major cardiac events that develop and the organ injury that sets in post myocardial infarction. Yeah.
So for this TIMI score, if the risk statistic, like the 30-day mortality that it suggests, it is post intervention or just on admission,
Before the procedure is done.
irrespective of the intervention.
Yeah, irrespective of the intervention. But if the TIMI score is more than 3, these patients they surely should undergo revascularization procedure. And higher the TIMI score, you will also have to start with these agratoban or integralin or eptifibatide infusions concomitantly when the patient is undergoing a procedure, because TIMI score of more than 3 means the thrombus load is very, very high. Okay, and in order to facilitate your procedure, these patients need an aggressive anticoagulation therapy, and then that's why these patients receive eptifibatide or tirofiban infusion. Dr. Vinod, you would like to say something on this? If you want to differ on
I'll
this?
again ask, there are some more questions here. There is one confusion regarding the timing. What is the standard recommended door to lysis time and door to PCI time?
Yeah.
Door to needle time is
With
30 minutes,
Santosh,
and door to needle time is 30 minutes, and door to balloon time is 90 minutes.
90
oh,
minutes.
yes,
Okay.
fantastic.
There is one more question, is that does the oxygen supplementation harm the patient of acute MI who are not hypoxic on room air?
Yes, sir. It releases superoxide oxygen-free radicals and may cause more inflammation. So we
Mhm.
have to target a oxygen saturation of up to 92%.
Okay.
Yes.
So,
The
yeah,
most
so
of the
recommendations have
guidelines
removed
recommend
oxygen therapy if the saturation is more than 94%. Yeah.
94% if the saturation is there, they may not be give to, because hyperoxia can have a harm on the superradical formation. Taken. Okay, we can. Uh, there is one more question. Uh, can you please mention which guidelines suggest to give anticoagulation in STME with in ER, whether it's a EC, ESC or AHA? So, do you have any answer, Santosh?
Oh, so guidelines I don't remember. I'll just
So almost all the guidelines recommend loading with antiplatelets, whether it is American Heart
Hey,
Association,
he's not asking
uh,
about antiplatelets. He's asking about anticoagulant.
anticoagulant like
Uh,
heparin or low molecular weight heparin.
yes.
I think it is recommended by American Heart Association, and I'm not sure about European Heart Association, but American Heart Association surely recommends a role of anticoagulant, either heparin or a low molecular weight heparin. The heparin can be given, unfractionated heparin can be given as a 60 unit per kg bolus, followed by 4,000 units and then 14 units per kg per hour infusion. And if low molecular weight heparin has to be given, it can be given at a rate of 1 milligram per kg subcutaneous. And low molecular weight heparin can be prevented if there is renal insufficiency. And there is definitely a role of clopidogrel in patients with myocardial infarction. Unless the patient has advanced age or diabetes, or patient has multivessel coronary artery disease, um, these patients should receive clopidogrel in the dose of 300 to 600 milligram per oral. And aspirin can be given in a dose range of 160 to 325 milligram. It's a chewable tablet now. I mean, you can ask the patient to chew. And definitely, these patients also should receive anticoagulation. But but if the patient is going for primary angioplasty, this anticoagulation probably can be avoided. This patient should be loaded with ecosprin clopidogrel, and straight away this patient should be shifted to the cath lab for the procedure. I hope you agree with me, Dr. Vinod.
Yes, yes,
Yeah.
completely.
So, what are the fibrinolytic agents that you know of, Santosh? Different fibrinolytic agent, and why do you use these agents? And what were the older drugs which were used for thrombolysis?
The fibrinolytic agents are classified as fibrin specific, non-fibrin specific. So non-fibrin specific were the older one that we used to use, that is streptokinase, urokinase. And the fibrin specifics are RTPA, that is recombinant tissue plasminogen activator, which are altiplase, retiplase, tenecteplase, which are more specific to the uh, uh, thrombus site and less risk of bleeding is seen with the fibrin specific fibrinolytic therapy.
Yeah. So there are different regimes available, Santosh and the audience. You can give tenecteplase. It is preferred if the age is less than 75 years and patient has presented with more than 4 hours of symptoms. If the PCI facility is not available, this tenecteplase can be given along with anticoagulant like enoxaparin or any low molecular weight heparin. So tenecteplase is basically based on the weight, whatever is the weight of the patient, and that much dose has to be given. If patient is 40 kilos, 40 milligrams of tenecteplase is given. So there are other regimes which are also available, like retiplase. But retiplase is recommended in patients with age more than 75 years. And retiplase is 10 unit IV bolus, and then it has to be given bolus over 2 minutes. And 10 units can be repeated over 30 minutes later. Yeah. So there are different regimes where half dose of retiplase and half dose of abciximab and half dose of unfractionated heparins are also given. But there is insufficient data pertaining to its therapeutic advantage over full dose of tenecteplase and retiplase. So these half doses may be indicated where the patient has renal dysfunction or patient is elderly age more than 75 years. But if the patient is less than 75 years, we should prefer to give full dose of tenecteplase weight based and retiplase 10 unit bolus followed by 10 unit over 30 minutes. The advantage with retiplase is it is quick, faster action, can be given. And then so you may have superior restoration of coronary blood flow with the IV bolus doses. So over to you, Dr. Vinod. Sorry, I took some time. Yeah.
The post thrombolysis,
Yeah.
till when can we go for PCI? If many times we get the patient post thrombolysis with ongoing angina.
Dr. Vinod, you would like to take this question?
Usually,
So there is no time frame basically. If even if you have thrombolized the patient and patient has ongoing chest pain, and you have a cath lab facility available, that patient should be shifted to the cath lab immediately, where we can actually see with angiography the benefits of thrombolytic. Sometimes the thrombolytic agents may be inadequate to thrombolize the clot. There may be a calcified clot. There may be a difficult to lyse clots. So in that situation, the primary angioplasty procedures, rotablations, or many other procedures can be offered, and the stent can also be placed. Dr. Vinod, you would
So
like to say something? Yeah, sorry.
yes, the same thing I want to convey is that the PCI is the standard treatment, treatment of choice. If you do not have available PCI and you're doing a thrombolysis and patient is stable, still the patient should be shifted to the PCI center. Whether the patient has got a symptom or not symptom, the check PCI also should be done if you have a facility available. That's what the standard guidelines say. Of course, if you do not have the PCI, then clinical judgment is okay for those patients. Again, my question is, you have mentioned one of type of circulatory support, that is the IABP. What are the other circulatory supports for MI, acute MI with cardiogenic shock?
Uh, So we have a assist device, left ventricular assist device,
Okay.
LVAD, RVAD, BIVAD, and we can also the newer modalities Impella we use, and
Mhm.
even ECMO.
So yeah, so
ECMO
the
can be
most
used for
commonly used nowadays is the VA ECMO, and
VA ECMO.
you can upgrade it to the Impala, and LVAD is usually for the long-term support. Okay,
Yes.
if the patient has got a heart failure, okay, for acute support, you don't need to go for LVAD, it's very costly. Impala is okay, IBP is okay, and VA ECMO is okay for those patients who is you want to intervene, like the patient is in shock, you want to do coronary angio, or the patient can be put on VA ECMO, and then you can go for that. Any other question? There is no any other question from the audience side also.
So, Santosh, my question to you is sometimes you may not see the patient classically presenting with ST elevation MI, and you may have a patient presenting with non ST elevation MI. So, would you like to offer thrombolytic therapy or PAMI or PTCA to these patients? Which are those patients whom you would like to shift it to the cath lab and do the definitive procedure in non-ST elevation MI?
For non-ST elevation in MI, uh, thrombolytic therapy is contraindicated. We don't do thrombolysis for NSTEMI. There
Yeah.
is increased risk of bleeding and other complications. And for NSTEMI, if there is usually if patient is having triple vessel involvement with NSTEMI, we can plan for coronary artery bypass later. Immediate uh, cath lab is not needed. And if patient is having NSTEMI with unstable hemodynamics, that is, if patient is having cardiogenic shock, we might have to do a PTCA for the patient.
So basically, I would like to reiterate on this. A non-ST elevation MI is categorized into three types: high risk non-ST elevation MI, and intermediate risk and low risk MI. So high risk non-ST elevation MI will behave like ST elevation MI. They may not have ST elevation, but they will have biomarkers elevated. So these are the patients who should undergo cath lab procedure. Okay, because these patients will have ST depression which will be more than 1 millimeter, and they will have ongoing chest pain, and the biomarkers will also be positive. So that non-ST elevation MI, you may not thrombolize, but you should shift that patient to cath lab, and the procedure should be done. ST elevation MI has complete occlusion of the coronaries. Non-ST elevation MI has partial occlusion. But if that partial occlusion is significant enough, especially in left main area or something like that. Even non-ST elevation MI may present like ST elevation MI. The biomarkers may be positive because there will be significant myocardial injury, and this patient should undergo revascularization procedures. But intermediate risk non-ST elevation MI, they may have ST depression, which will be less than 1 millimeter, and the biomarkers will be negative. This patient may be screened. Usually, these patients are managed with antiplatelets and anticoagulations, and antiplatelets are continued for at least 12 months, and these patients should be followed up. Initially, they may receive dual antiplatelets, and anticoagulations can also be offered, but later on they may be discharged with dual antiplatelets and followed up frequently, and 2D echo should be done every 6 monthly. But if the patient has presented with low risk MI, this patient will have atypical chest pain. That may not be classically present on the left side, and their biomarkers will be negative, and the ECG will also be absolutely normal. So this patient can be subjected to, stress stress procedures, and then echocardiography can also be done, and myocardial function or regional wall motion abnormality should be ruled out, and this patient can be shifted or discharged without antiplatelets. So basically, it is important. Even non-ST elevation MI may need a cath lab procedure on urgent basis if it is high risk non-ST elevation MI. Dr. Vinod, you would like to say something on this or anything to be added?
You have, no, no, I think you have covered very
Yeah.
nicely.
So, what are the complications that
Just
you see,
concentrating
Santosh?
on some questions.
Post
After,
myocardial infarction complications.
yeah,
Yeah.
yeah, you can discuss them.
Yes, sir.
So, what sort of complications you may have after myocardial infarction?
So we have post MI pericarditis, that is restless syndrome. We have arrhythmias. Patient can have post reperfusion arrhythmias, can be ventricular tachycardia, atrial fibrillation. That can be supranodal or infranodal arrhythmias. Uh, Patient can have ventricular septal rupture. Patient can have papillary muscle rupture. Patient can have ventricular free wall rupture, and these are the mechanical complications. And
Yeah, they may have aneurysm, also LV aneurysm may be seen in some patients. It may not be very common, but it is usually seen in patients with basically infero-posterior aneurysms, and in the territory of LAD, the LV aneurysm may be seen. So these patients should be followed up, for, at least every 4 weekly, and the treatment of aneurysm. The problem with the aneurysm is formation of LV clot. So these patients will need anticoagulation, on long-term basis, and these patients should have repeated 2D echocardiogram to rule out LV aneurysm. Yes, as you said, arrhythmias are very common. You may see arrhythmias post reperfusion. These are called as reperfusion arrhythmias. It settles down after some time. You don't really need to give CPR or anti-arrhythmic agents. But if these idioventricular rhythm persist for a long time, maybe ventricular tachycardia, yeah, and it is causing hemodynamic compromise, that can be corrected. So usually the potassium correction, magnesium correction is also sufficient when these patients have arrhythmias or tachycardias, and if persistent is ventricular tachycardias are present, then these patients should undergo uh, defibrillation, or cardioversion can also be offered to this patient. Pericarditis and effusion is usually seen in patients maybe 24 hours to 4 weeks after the infarct. And that's why it is usually seen in transmural infarcts where you have through and through infarct. and it should be distinguished from pericarditis. Patient will have classical pain, chest pain, which may be radiating to the scapula or maybe radiating to the shoulder, opposite shoulder. So basically, it settles down within 1 to 8 weeks of presentation, and this is generally a systemic inflammatory response that is seen post MI when patient presents with pericarditis or effusion. Left ventricular failure is also very common, but it can be treated with diuretic therapy and probably patients with those patients where afterload reduction is achieved. So that is sufficient. And if the patient presents with rupture of free wall or ventricular septal defect or papillary muscle rupture, this patient should be immediately treated because it may be life threatening at times, and a surgical colleague should be invited, and his opinion should be taken, and some patient may need surgical procedure and correction in these patients. Yeah, Dr. Vinod, you can go ahead with the questions. Yeah.
So there is very interesting questions here also, and one is that somebody has asked me, kindly highlight on the Whelan syndrome and the winter ECG changes. This is Rupak Banerjee is asking, and also tell something about RBMI. So Dr. Santosh, this is one question: is Whelan syndrome,
So Whelan
and one
syndrome
is
is basically patient initially has chest pain, presents to the ER. The ECG done initially is normal, and after 2 to 3 hours, patient develops biphasic T waves, and which is classical for uh, critical LED, proximal LED occlusion. It is Whelan syndrome.
Yeah, Santosh, you rightly said that this Valen syndrome is usually
okay.
seen.
So
Yeah.
biphasic inverted T waves.
Yes, sir.
So basically,
Another is one D winter CCD also.
So D winters, D winters, I don't remember.
pardon, what was the question asked?
No, one is a type of ECG they have mentioned.
You are not audible.
Is the kindly tell me about De Winter's ECG. Yeah, De Winter's ECG.
So D winter
You
CCG.
can
I'm
see
not.
in the chart box.
Yeah, I'm not. Yeah, I'm not sure about D winter's ECG
Yeah,
changes.
as far as yes, not again it is related to the ECG changes of the left atrial descending, and actually it is early sign of one of the LED disease. Uh, uh,
Sir, actually, your voice is breaking.
there is one more question. Am I audible now?
Yes.
Yeah. So basically,
Okay,
I
there
want
may
to
be some
highlight
internet
about the
connection
winter
problem.
ECG changes. Dr. Vinod, I would like to highlight the important aspects of the winter ECG changes. So basically, it suggests
Yes, yes, tell me, sir.
high risk coronary syndrome, particularly when patient presents with anterior wall MI. So we tend to see the winter ECG changes. It is seen as upsloping of the ST segment depression.
Okay.
It is usually seen in leads V1 and V3. There may be upsloping, there may be sagging, and they will also have prominent R waves in lead V1 and V3, and ST elevation may be present in lead ABL. So basically, these are highly suggestive of acute coronary syndrome, especially with anterior wall MI and left anterior descending artery occlusions. So basically, prompt recognition of deep inter ECG changes is crucial because it may indicate very high risk entry wall MI. And if we delay the treatment when deep inter ECG changes are there, the myocardial damage is substantial, and these patients may have significant drop in ejection fraction, and these patients may present with poor outcome. So it is also seen in some electrolyte disturbances with hypokalemia or patients with left ventricular hypertrophy also. These patients may have deep inter ECG changes. So that's why clinical evaluation is very, very important. And biomarkers also should be evaluated. And the angiography also will be very important, very crucial in these patients, because if this is missed, these patients may have poor outcomes. The morbidity and mortality is very high. Yeah, that's all from my side, sir. So, what is the ABCD approach when you discharge this patient and you call for follow up? So, what is ABCD approach, Santosh?
ABCD is airway, breathing, circulation. So first we, as any critical patient comes to ER, first we manage the airway, secure airway. If it is threatened or threatened airway, we have to secure airway, start ventilatory support. And for circulation, we start IV fluids as per the hemodynamics and hemodynamic monitoring. We start the IV fluids and maintain the blood pressure and map and ABCD.
No, basically, I think you took it as differently, because I've asked you ABCD approach when you discharge the patient with acute myocardial infarction. You talked about the admission
Okay.
criteria. So basically, when you discharge the patient, you should give ABCD approach to your patients. This patient should receive antiplatelets. Aspirin should be given indefinitely, and heparin or enoxaparin can be given when the patient is hospitalized, but heparin or low molecular weight heparin is not given post discharge. All these patients should receive AC inhibitors as far as possible if the patient's ejection fraction is less than 40%. And you can give angiotensin 2 receptor blockers if AC inhibitors are contraindicated in these patients. B is beta blockers. You should give beta blockers to all the patients, except when the patient presents with hyperacute phase. But later on, post discharge, patients should receive beta blockers, and beta blockers have been found to reduce morbidity and mortality related to the disease. And blood pressure monitoring should be important, and blood pressure goal should be less than 130 by 80. Or if the patient is diabetic or chronic kidney disease, then you can accept a blood pressure of 140 by 90. So blood pressure monitoring and beta blockers are the mainstay of the therapy. If the patient is smoker, like your patient is smoker, there should be complete cessation of the smoking. And if the patient has withdrawal symptoms, nicotine replacement also we can give. And we can also advise counseling, for this patient. And cholesterol, C is cholesterol. The goal, the lipid profile should be evaluated on routine basis, and the LDL should be less than 70 milligram percent, and HDL is targeted more than 40, and HbA1c should be less than 7%. And we should also give dietary advice to the patient, and they should reduce the weight, and they should also reduce the calories by more than 500 calories, you know, if at all they are taking. And you should advise exercise. E is exercise, 30 minutes walk, at least 4 days a week should be given to the patient. And they should undergo cardiac rehabilitation, and ejection fraction should be monitored every 6 monthly. The 2D echocardiogram can be done, and as the cardiologist advises, the EF evaluation should also be done on every 6 monthly or 1 yearly or something like that. So this is what is ABCD approach. And this can also be asked in exam. Yeah, Dr. Vinod, you would like to say something? Yeah.
Again, there is one more question is in which condition am I patient transferred to defibrillated? Is it due adjacent after ambu bag? I don't know what is the meaning of the question. Somebody asked, Dr. Kastub has asked, Kastub Kar. Any idea, Santosh, about this question?
Sir, I didn't get the question, what is written.
Yeah, also I failed to understand.
So he may be asking when the patient needs defibrillator. If the patient has intractable arrhythmias, ventricular tachycardia, ventricular fibrillation, unstable rhythm, that patient should receive defibrillation.
So all patient VT and VF and VP
Yeah,
with hemodynamic
instability.
Yes. So I think this is the end of the question.
Yeah. So, any role of IBP? Any trial which has shown the benefits of IBP? Santosh?
IIBP shock 2 trial was done, but there was no significant mortality benefit. But it was only helpful in increasing the mean arterial pressure and used as a bridging therapy to the definitive therapy. But no 30-day mortality benefit was seen with
Yeah.
shock 2 trial.
Yeah. So that's absolutely right. IBP, the role is for 24, 48 hours, maybe maximum 72 hours. Beyond that, it has no role, and it has no definitive advantage. It is just a bridging therapy till the patient undergoes some procedures, maybe CABG, or maybe if the patient's heart functions are not improved, it can be a bridging therapy for ECMO. It can be a bridging therapy for heart transplantation. Okay. If the patient presents with, post CPR status and the patient's cardiac functions have improved, but revascularization is not possible, patient is very unstable and very high risk for revascularization procedure, early institution of ECMO is also advisable in such patients. Do you want to say something about ECMO, Dr. Vinod?
I think you have covered nicely that patients who are not a candidate for the revascularization due to the hemodynamic impact. Meanwhile, to improve and to save the life of those patients should be put on the mechanical circulatory support, and ECMO is one of the options to put them on the mechanical circulatory support. Short-term ECMO.
Yeah. So those patients, even ECMO is also bridging therapy, and it's not a definitive therapy. If the myocardium improves, it's fine. But if the myocardium doesn't improve, you may have to think about heart transplantations in these patients, or there are assist devices which are available, either left ventricular assist device or right ventricular device. We call it as LVAD or RVAD. And if there is biventricular failure, we can offer BIVAD procedures to these patients. Nowadays, these VAD procedures have become a destination therapy where heart transplantation is not possible. So these VAD procedures can become a destination therapy, and people can live with these VADs inserted inside the heart. Basically, these VADs they work as a pump. They if it is LVAD, left ventricular assist device, the pump is inserted in the left ventricle, where it draws the blood from the left atrium, and it directly ejects the blood into the aorta. And if it is right ventricular VAD inserted, the VAD is there in the right ventricular, and it directly receives the blood from the right atrium, and the blood goes into the pulmonary artery. So these VAD procedures can be temporary. This can be permanent. Okay, and these are battery assisted devices. The patient has to be on battery lifelong. And sometimes the if the heart is not available, these VAD procedures also can be bridging therapies till suitable heart is available for transplantation. Yeah, that's all from my side, Dr. Vinod. Yeah.
Yes, I think you have covered all the mechanical circulatory devices. The Berlin heart for children are also available, which can support the heart in And when it can be a destination therapy, it can be for the transplant, waiting for the transplant also. I think we have covered almost all parts of the acute MI, starting from the emergency management and going to the in-hospital management. How do you assess and when do you discharge? What are the complications related? Who are the patient who needs to be circulatory support? And finally, when to discharge and what investigation should be done. It is nicely presented by Dr. Santosh. Anything else, sir, you want to tell?
Yeah, I think it is nicely presented. Any other questions, if at all we have, we can take these questions or we can wind up the session. Sushmita ji, uh, is it okay if we can wind the session because we have to consider the time also?
Yes, sir. Yes, sir. So we can conclude now.
Okay. Thank you, Dr. Vinod.
Yeah,
Uh,
thanks. Thanks, sir. Nice meeting you again.
Yeah,
We will
yeah,
talk.
me too, me too. It's really very exciting to see you on the platforms, and students also learn a lot from you. And looking forward to see you again, maybe in
We will meet
coaching.
in
Yeah,
Kochi. We are meeting
yeah,
in Kochi, sir.
yes, 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 yes.
Okay, thank you. And thank you, everybody,
Sure,
for
sure.
your
Thank you, sir.
patience.
Thank you very much.